Hello everyone, thank you for joining me today. I'm going to discuss my IRB proposal with you guys. My name is Abby Oda. So the research that I'm proposing regards iron supplementation in female adolescents with heavy menstrual bleeding and an iron deficient status diagnosed through low serum ferritin. So iron is very important to the survival of all living things. In humans, it is necessary for oxygen transport, the transfer of electrons, oxidation reduction reactions, DNA synthesis. Roughly 60% of our circulating iron is actually found in the blood. The other 40% is found in other tissues like the organs and muscles. The fact that the majority of the blood circulating in our bodies is found in the blood is very important, especially considering trauma in which there is great blood loss or heavy menstrual bleeding or different things like that. The body only absorbs 5 to 35% of the iron that it consumes, and this is affected by your iron status. So if you're deficient, you'll absorb a greater amount. If you have a healthy iron status, you'll absorb less, so more in the 5% range. It also depends on the type of iron. So heme iron is found in animal products and is easily absorbed by the body, but non-heme iron is found in plant products, and it is much harder to absorb by the body than heme iron. It also is affected by the presence of vitamin C, which enhances absorption. Other minerals like calcium actually decrease the absorption of iron, and it also depends on age and weight and things like that. In the human body, iron status is regulated simply by absorption. There is no excretion process for iron. It's only lost through daily fecal loss and menstruation and things like that. There's no way for the body to lose iron when it has too much. It just regulates everything through absorption. So when there is not enough iron over time, this can produce iron deficiency, which can lead to iron deficiency anemia. In iron deficiency, over time, the different bodily functions that require iron can fail or malfunction, and this can lead to iron deficiency anemia, in which there is not enough red blood cells in the blood, which is usually read through serum hemoglobin, and it'll show that you don't have enough red blood cells. And this is just due to the fact that because there's not enough iron, we can't make those red blood cells, and because there's not enough iron, we can't transport oxygen. This can lead to tiredness, learning delays, poor wound healing, weakness, reduced thermogenesis, reduced ability to focus, increased overall morbidity, mortality, and especially increased morbidity and mortality in a fetus if you are pregnant. This all can be exacerbated by heavy menstrual bleeding, and in adolescents, they're also growing. So there are greater iron requirements for those that are growing as well as those that are menstruating. So that combined can be a big problem. So overall, the objective of this study is to compare the rate of serum ferritin increase through iron supplementation in adolescent girls with heavy menstrual bleeding and an iron deficient status. And that will be looking at 2 different doses of ferrous sulfate. So if a weekly dose of 325 or a daily dose of 150 milligrams of ferrous sulfate will be more effective or will produce greater or lesser symptoms and side effects. So I reviewed 12 total studies. 3 of those were retrospective and included several other studies and many participants. And then the other 9 were either observational, controlled, or pre-test, post-test studies. That literature ranged from data regarding iron deficiency anemia, and iron supplementation to the quality of life for those with iron deficiency and iron deficiency anemia, as well as quality of life for heavy menstrual bleeding patients. And then that progressed to studies that had to do with iron supplementation in women with heavy menstrual bleeding and iron deficiency or iron deficiency anemia. And then I did find one study that had to do with iron supplementation in adolescents, and eventually one with adolescents with heavy menstrual bleeding. But there was far less literature that had to do with adolescents with heavy menstrual bleeding and iron deficiency status that looked at iron supplementation. That was few and far between. All right. So subjects involved in this study are going to be subjected to weekly or daily oral supplementation according to which group they're randomly assigned to. They will be taking in ferrous sulfate, and it will be in levels that are previously reported as safe and are used in many of the studies that I reviewed in my literature review. This would provide quantitative data that we could review, and in addition to that, we would also have 2 identical surveys that would be administered at 30 and 60 days of the study. This would provide qualitative data for the study and treatment formulation in the future. So it would tell us, what symptoms they faced and which was easier to do, and how best we could go about that in the future. So participants will be recruited through the obstetric gynecology office records via nurse request during just routine office visits within the recruitment time frame. They will be given 2 weeks to decide if they would like to be included in the study. And consent will be very important. It will require the parent and the adolescent's permission, and they will be presented with all of the activities that they will have to face, which would include the venipuncture for the ferrous sulfate, or for the serum ferritin levels and hemoglobin levels, as well as the surveys that they'll have to fill out. Prior to treatment, they'll be given the venipuncture, and that will also be taken at 30 and 60 days. The patients will have to be between the ages of 14 and 18 and will have to have self-reported heavy menstrual bleeding and a predetermined iron deficiency anemia, or just overall low serum ferritin levels, either in previous blood reports or in blood levels taken at that time. As I said, the guardian and the participant permission is very important. We will need both because they are adolescents. And a $20 gift card to Starbucks or another comparable store in the area, whatever is easiest to obtain, will be an incentive for participation in the study. Subjects that are previously diagnosed with von Willebrand disease or hemophilia or any other bleeding disorder will not be excluded from the study, as usually von Willebrand or hemophilia are related to heavy menstrual bleeding in adolescents, and they also face issues with iron deficiency and things like that. So it should skew the results. An a priori test was run to determine the sample size that would be appropriate for this study. It determined that we needed 172 participants, which was 86 subjects per group. Taking into account the possibility of dropout or poor compliance or other complications, we would like to have 100 participants per treatment group with a total of 200. We found this number, the 86 subjects per treatment group, using G-Power. It was entered as a two-tailed t-test with a power of 90% and error probability of 0.05 and a medium effect size of 0.5. And I've also included a screenshot of this so that you can see exactly what we did and what the sample size was there. Quantitative information will be recorded digitally and submitted by email to the researchers using only participant identification numbers that have been given randomly. The qualitative data will be recorded on paper by each participant and faxed or mailed in with only the participation identification number. So the only records for the identification number and their identifiable information will just be available at the doctor's office by doctor's office personnel, not by researchers or anyone else. The researchers will only receive the ID number and the relevant information, the quantitative and qualitative data. Confidentiality will be maintained using that system. The identification numbers, no phone numbers or names or other identifiable information will be used to label or keep up with each participant. The data will be submitted by clinic personnel digitally, not the subjects. And the only time personal information will be obtained is during the recruitment process in order to screen and contact individuals. The ID numbers and treatment groups will be assigned randomly, and all the other personal information such as numbers, names, emails, anything like that will just be wiped from it, will be removed from any data that is accessible by the researchers. And like I said, the doctor's office will be the only source of the IDs in conjunction with the names, since they will be submitting the information. The research will take place only at the doctor's office by the personnel that are, trained, so either phlebotomists or nurses will do the venipuncture, things like that. All the blood draws, lab tests, and surveys will be completed there. Everything will be supervised by either the nurses or the doctors. The researchers will not be participating in any of the activities as the venipuncture or the surveys, just to remain blinded, as not to skew any results or anything like that. And the only risk that we anticipate the participants being exposed to would be the side effects possible that occur alongside ferrous sulfate supplementation. According to the literature I reviewed, that's usually in daily supplementation. Some of these symptoms could include nausea or other intestinal upset, such as stomach cramps, things like that, just overall GI upset. Some direct benefits of the study could result in improved serum ferritin, iron deficiency, and iron deficiency anemia status in the participants, and indirectly as improved deficiency treatment and diagnostics in adolescents and adolescents with heavy menstrual bleeding. So they could see some direct benefits from the symptoms of iron deficiency, as well as indirect benefits from future diagnostic and treatment. So the data analysis will be completed using SAS software. It will be utilized for the data analyses to compare the means of the two treatment groups. A two-tailed t-test will be run to demonstrate the variance in results for both means, and the p-value will also be examined in order to review the statistical significance of the variance. And that'll tell us if the serum ferritin improvements are comparable, or if they are, statistically insignificant. So if they're, so close together that it doesn't really matter, or if the difference is great enough that it actually means something, that, that could show a difference in the administration and effectiveness of the ferrous sulfate tablets. Excuse me. This will all be done to either accept or reject the null hypothesis that weekly administration of 325 milligrams of ferrous sulfate weekly will not increase serum ferritin levels to adolescents with heavy menstrual bleeding and low serum ferritin with fewer side effects than 150 milligrams of the ferrous sulfate once daily. And this is contrary to the research hypothesis that the 150 milligrams daily administration of ferrous sulfate will produce greater side effects and be less effective than the 325 milligrams weekly. So that's about all I've got for you guys. I hope that was clear, and that you understand my research proposal a little bit better. I feel like it would really fill gaps in the research, especially for adolescents with heavy menstrual bleeding, as they are growing, which requires more iron, and also have heavy menstruation, which can really reduce iron status. So I think it's very important. You heard the different symptoms of iron deficiency and iron deficiency anemia, and when you pair that with the lower quality of life in those with heavy menstrual bleeding, I think it can really take a toll. And it's really important that we understand the treatment and diagnosis of iron deficiency and iron deficiency anemia in adolescents with heavy menstrual bleeding. Thank you guys for listening in, and I hope you have a wonderful day.